Hi there. My name's Louise Knowles and I'm Head of Mental Health Counselling and Therapy Services at the University of Sheffield. And this presentation is on our approach to clinical governance. So I'm going to talk you through our approach at the University of Sheffield. So first of all, I want to talk to you about what I call the ecosystem of clinical governance. So our governance here is made up of these areas. So there's our corporate governance, if you like, governance that's around how we operate as a business and as an educational establishment. We also have our own internal clinical governance structures, which I'll talk about in more detail. And then there's external governance, so if you like, external bodies. And obviously there are a number of external bodies that relate to corporate governance, but I'm not going to touch on those. I'm going to touch more on the clinical governance side. So for us, there's the NHS and our professional bodies, so things like BACP, British Psychological Society, Health Professional Council, and bodies such as those, as well as our external accrediting body for our clinical services, which is APS, which is Accreditation for Psychological Therapy Services. And also, obviously, Student Minds, because Sheffield was successful in gaining the charter. So that's the ecosystem, if you like. That's everything that that will sort of have an impact in terms of how we approach our governance structure. So what were our drivers for clinical governance? Well, one, we wanted a critical friend. We certainly wanted a friend, but we also wanted someone that might point out our weaknesses. We certainly wanted to hold ourselves to account, and I'm certainly quite a advocate of public accountability. Like most services, we wanted to continually improve, and also we wanted to take account of many different pools in terms of governance. So we didn't just want one primary one, if you like. And we wanted this to underpin all our work with students. And for me, the fundamental difference between clinical governance and corporate governance is clinical governance is to do with really about care. Rather than about business needs. So our approach to clinical governance, we wanted an external quality mark. As I say, we wanted an external clinical friend. We wanted something that we could be proud of, and something that would unify us as a multidisciplinary team. So we're not just counsellors or mental health professionals. We're a collection of different disciplines. We wanted something that staff and students would understand, or that we could easily educate them about. So something that was easy to get across. And for me, it's business critical, and it offers a protected quality to embedded services. So I wanted something that would protect the quality of what we offer and the uniqueness of what we offer. So what influenced our approach? Well, we're a Russell Group university, so there's an emphasis on research. We've got a long history of providing an in-house counselling service, although interestingly, we were one of the last Russell Groups to provide an in-house counselling service. We have our own in-house GP practice, and I think that had a significant impact on us, and something that we're very proud of. We're in the north, and Sheffield has 2 universities, so there's a large population in Sheffield. And also locally, the health inequalities in Sheffield are significant, with issues of poverty. So what we didn't want to do is compete with the local population. And so, if you like, our approach was that we pride ourselves in our civic responsibility to the local community. So we wanted to work in conjunction with the local community. So, for example, we didn't want students having better access to mental health provision than people in some of the more deprived areas of Sheffield. So who did we choose? Well, we chose the Accreditation Programme for Psychological Therapy Services, APS. So APS was developed through a partnership between the Royal College of Psychiatrists and the Centre for Quality Improvement at the British Psychological Society. So the reason why I went for those really is I think most people have heard of those. And also the purpose of APS was to support learning and improvement in the delivery of sustainable, high quality, safe and compassionate care. So for me, that was a relatively easy message to get across. The accreditation standards have undergone stakeholder evaluation. So what that means is, services like ours have reviewed and revised the standards, but more importantly, service users have. And one of the things that I really like about apps is how it integrates with service users. So a bit more about apps. So there are 57 standards and they fall into 5 key areas. And the key areas are, is it caring? Is it safe? Is it responsive? Is it effective? And is it well led? And that's the latter one always brings me out in a bit of a sweat. So 57 standards, and there are 2 types of standards. Type 1 standard, so this is a minimum, you've got to meet those, and Type 2 standards demonstrate high quality service. So if you get the Type 2 standards, then you're pretty good. Type 1 is often what we just aim for. What does it involve? Well, it involves a comprehensive workbook, and that workbook can be a bit of a labour of love. Questionnaires are sent out to staff and to service users ahead of a site visit, and the site visit consists of a focus group with staff and service users, as well as your management team as well, and they're interviewed. So there's an external audit team involving clinicians and service users. So, for example, some of my staff have gone and audited other services. There's a mid-accreditation review every 18 months, with a full review every 3 years. So what impact has this had on our service? It's not necessarily about what we do, but more importantly about how we do it. So what changes have we made? So we've been APPS accredited for 9 years now, and over this period we've undergone 3 major reviews. The main changes have been about establishing and maintaining a comprehensive clinical handbook, which has been reviewed and signed off each year by staff. Changes are highlighted each year, and staff are supported with shaping this key document. If you like, it's our go-to document. So this handbook, if you like, includes areas such as risk management, confidentiality, its limits, referral pathways, trusted referral from accredited services within the NHS. So that's one of the things that we've been working with for a number of years now. It offers a steer on things like supervision, external and internal, and how we approach staff support. So the changes that we've made here have been, there's a better focus on service user feedback. So again, we've integrated that more systematically. It's a result of apps. It's certainly collected more regularly, certainly through our waiting room and through our contact with clients. More recently, we've redesigned our service, and we redesigned this on the basis of the feedback that we sought from students. So you can catch up with the changes that we've made. There is an article in the BACP Universities and Colleges Journal that sets out some of the changes, so I'm not going to expand any further there. I guess the most significant changes have been our focus on embedding session-by-session measures, and we use a measure called CCAPS, which is an American model, measure, but it has been validated for UK use. I think there are positives for us as a service. I think there are positives for practitioners, and there are certainly positives for me as a manager. I think as a service, it shows whether we're effective, it shows what we're doing, what our weaknesses are, and what our strengths are. And again, as a practitioner, it shows you how you're doing in that piece of work you're doing with that particular client is doing, and where you might want to focus your interventions. And as a manager, it helps you sort of focus where support might need to be for a particular clinician. So if they're particularly struggling with anxiety, you might want to increase the amount of training or support that you put in for that particular practitioner. So outcome measures and clinical governance, as I said, we use session by session clinical measures, and this enables us as a service to understand whether we're effective. So I've sort of briefly touched on this, and I'm going to expand a bit further now. It helps us compare ourselves to other similar institutions, both in the US and UK, and we do this mainly through the SCORE Consortium. And again, you'll find a link for that if you Google SCORE Consortium. It's a consortium of other universities that are collectively pooling their data. But it also enables us to contribute to research, and which, as I said earlier, you know, as a Russell Group university, that's really important to us. It gives us a voice, if you like, but more importantly, it gives students a voice in terms of utilising their data productively, if you like. It encourages our institution to ask us how effective we are. It's not just about waiting times. And if I have a wish, it would be that I'm asked much more about how effective we are rather than how long the wait is. Wait times are meaningless if the service that you're offering is not worth waiting for. And it also enables us to understand more about the psychological makeup of students who present to us. So what levels of distress do students present in? Is it high levels of distress? Is it moderate? Is it low? But collecting session by session clinical data enables us to make those assessments. So from a practitioner point of view, and as I say, I've briefly touched on this, but I'll just expand a bit further here. It enables us to see the level of distress and general psychological makeup of the client ahead of the client entering the room. So we get that data just before the client enters the room. So if you like, you're already formulating how you might approach the session and what might be needed. Often clinicians will share the clinical measure with the client and talk to the client about what they think and whether they think it's representative of what their struggles might be. And more importantly, offers a clear focus for the clinical work. And finally, it highlights if things are going wrong. So if a client is struggling to say they're not getting what they need, they might actually find it easier to communicate that through the clinical measure. And for managers, so for people like me, it enables me to better understand the levels of distress in the service. So, you know, as a population, if you like, what's happening, and do I need to pull in anything else in terms of helping us meet the need that is within our institution. It also enables me to see what each individual practitioner is carrying, and do we need to ease up in terms of some of the more complex cases for them. So I guess it's about weighting of each cases. It also enables us to understand where staff strengths and weaknesses are, you know, to enable development for that individual practitioner, like where will we focus training for that individual practitioner. And so I guess it's influenced and helped us to develop our interest in research, collecting session by session clinical measures. And for me, that is the language of higher education. We're also in the process of developing a training and research clinic. And what we mean by this is that we offer training placements for trainees, trainee clinical psychologists, counsellors, psychotherapists, and maybe in the future, social workers and mental health practitioners. And this is we're also engaging with a number of research initiatives. And as I said, mainly through the SCORE Consortium, but other more low level, if you like, research initiatives that some of our master's students on the psychology course have come to us with, because they're interested in student mental health. And if we didn't have that data, we wouldn't be able to work with them. So reflections on future challenges. What and how have we been influenced by the Charter? So we gained the mental health award status in July 21. And we currently have significant changes within the institution, and the challenges for us is ensuring that these changes don't negatively impact on the principles of good practice and our charter status. And I think that is a precarious balance at times, and one that I suspect that quite a few institutions may begin to struggle with. Changes to provide to this provision under my leadership. So things like I'm now responsible for a school-based wellbeing advisors. So we need to recognise, we need to reconsider our clinical governance, if we like. And for us going forward, apps may no longer be a fit. It may no longer be fit for purpose in terms of our clinical governance. But we will be taking into account BACP and certainly the UNHAM governance guidance that I think is really helpful to the sector, and find ways. I think for us, one of the things that I really want to do here is find ways of harnessing the student voice. And I also want to pay attention to clinical governance, that it's not easy, but it's definitely worthwhile. I think as the sector changes, it might feel more weighty, but I certainly think it's more worthwhile, as it offers you and your service a secure base from which to practice. And that concludes my presentation. Thank you for listening.